Good afternoon, everyone. Welcome to the Wednesday afternoon lecture series. For those who are in the room, I very much appreciate you braving the icy weather to come on campus to be in the room. For those who are watching online, I appreciate that and I hope that you're in a warm and safe place. Get a hot chocolate or something, and watching this would be a nice treat. Today, so this is a first of the 3 special NIH Directors Lecture this WALS season. These speakers are selected among almost 200 WALS nominations by the NIH Director, in this case by Dr. Lawrence Tabak in his role as the acting NIH Director when the 2023-2024 selections were made. Dr. Monica Bertinelli, the NIH Director, was supposed to introduce our speaker today. Now, unfortunately, she couldn't make it in because her flight got canceled due to weather. So you got me, a much less important person, introducing the speaker. I am Kelvin Choi. I'm the Acting Scientific Director and the Senior Investigator at the National Institute of Minority Health and Health Disparity Division of Intramural Research. I'm here also on behalf of the NIH Health Disparity Interest Group, who nominated our speaker today. Now, for those who are watching remotely, we're encouraged to participate in the Q&A after today's presentation. You can do so by clicking on the button just below your videocast window, which says Send Live Feedback. Click on that, type in your name and question, and we will relay this information to Dr. Hemingway at the end of his lecture. You can submit your question anytime. For those in the audience, you can see we have 2 microphones in the audience. You can either use the one on the left or on your right, whatever closest to you, or you want some exercise, whatever further away from you. And you can ask questions after the lecture. Now, we also offer continuing medical education credits for this presentation. The CME code for today is 50108. I repeat, 50108. Now, let's turn to the business. Let me introduce our speaker today. In 2016, following the deadliest mass shooting in the U.S. at that time in Powell's, Florida, the American Medical Association declared that gun violence is a public health crisis in the United States. However, since then, the crisis has only gotten worse. In 2021, there were 48,830 gun-related deaths, a 23% increase from the 2019 number. Even worse, gun death among children and teenagers rose 50% during those 2 years. It's also important to know that gun violence is disproportionately affecting communities experiencing health disparity. Now, since gun violence is a public health crisis, we need a public health approach to address this crisis. So today, we are very fortunate to have Dr. David Hemingway, Professor of Health Policy at the Harvard T.H. Chan School of Public Health and the co-director of the Harvard Injury Control Research Center, to talk to us about this public health approach. Dr. Hemingway is an award-winning expert in firearm violence prevention. Among many of his recognitions, he was recognized by the CDC as one of the 20 most influential injury and violence professionals over the past 20 years in 2012. He has won 10 Harvard School of Public Health Teaching Awards and the inaugural Student Association Committee Engagement Award. In 2020-2021, he was a Radcliffe Fellow, a distinction reserved for exceptional scientists, writers, scholars, public intellectuals, and artists whose work is making a difference in their professional fields as in the larger world. Dr. Hemingway received his undergraduate degree in economics from Harvard University, his master's degree in economics from University of Michigan, and his PhD in, as you guessed it, economics from Harvard University. Since 1997, Dr. Hemingway directs and co-directs the Harvard Injury Control Research Center. He has written 5 books and over 265 journal articles. His books include Private Guns and Public Health, and While We Were Sleeping, Success Stories in Injury and Violence Prevention. He has made significant contributions to the firearm literature in the area of gun ownership, gun training, gun threats, gun homicide, self-defense gun use, and public health approach to reduce firearm violence, and many other issues involving firearms. So in light of the cold weather outside, please help me and give a warm welcome to Dr. Hemingway.
Thank you. So I'm going to talk about guns, and I'm from New York. I'm going to talk too fast. So I'm going to talk about that guns are a big public health problem. I'm going to talk about the public health approach. I want to talk a little about the importance of data and research since I'm here. And I'm going to look at two areas: unintentional child firearm fatalities and suicide prevention. So we know exactly how many people are shot and killed each year. We only know approximately how many are shot. We only know approximately how many criminal incidents there are, but all these things are a lot. And what we do know is that if we do nothing over the next decade, more than 1 million Americans will be shot. If we look at the data, we have a lot of suicides, a lot of homicides. Most of our suicides are firearm suicides. Most of our homicides are firearm homicides. If we talk about homicides or suicides in the United States, you have to talk about guns. There are more firearm suicides than firearm homicides. And of course, there are many other problems than just people dying. There's a lot of non-fatal injuries, spinal cord injuries, and so forth. There's a lot of intimidation with guns. There's a lot of robberies with guns. We know now that the evidence is more and more every year about how exposure, particularly to firearm violence, increases the risk of long-term trauma, long-term physical problems, long-term mental health problems. And then there's all these other problems associated with guns and gun violence. The key thing is that gun violence among high-income countries is a uniquely American problem. We are a conspicuous outlier compared to the other high-income countries, the 30 or more countries. We are very similar to most of these other countries in lots of ways. One way, we have similar non-gun crime rates in terms of things like sexual assaults and robberies and so forth. We have similar violence rates. We have, when studies are done about in schools, we have similar bullying rates, similar aggression rates, similar depression rates. But we are different in one big area in that we have very different guns than they have. We have lots more guns. We have particularly more handguns than are available elsewhere. And over the last 20 years or so, we have lots more military weapons in civilian hands. And compared to every one of these other high-income countries, we have by far the weakest gun control laws. This just gives you a feeling about the size of our problem relative to other high-income countries. It's going to looks at 5 to 14-year-olds. The reason I look at 5 to 14-year-olds is because it's hard to blame the victim. And there's a lot of victim blaming in this area. These are kids who are basically K through 8. And what this says is that a child in the United States, K through 8, has a lot higher risk of gun homicide than being a victim than a child in Canada or in England or in France or in Japan or in Korea or any of the other 30-plus high-income countries. And it's not 50% higher or 2 times as high or 5 times as high. It's almost 27 times higher. Our gun suicide rate among these children is 27 times higher. A child, a 14-year-old, flunks a class, or his little girlfriend breaks up with him, and he comes home, he finds his dad's gun, bang, he's dead. Our unintentional firearm death rate compared to these other children is 8 times higher. I teach at a public health school with lots of international students, and they just look at me, and if I show them any data like this, and they say, why don't you guys do something? And it's very hard to explain. Let me talk about the public health approach. I've been trying to promote the public health approach for 30 or more years, and it's actually, we're having some success, some traction. More and more you hear progressive police chiefs in cities saying, we can't arrest our way out of this problem. We need to do something else. We need a public health approach. And people are talking about the public health approach. I don't think they know exactly what it means. Here's what it means to me. A one-sentence description of the public health approach would be, let's make it easy for people to stay healthy. Let's make it hard for them to become sick or injured. I do a little work in obesity prevention because there typically hasn't been enough money for me in the gun research area. And what does this mean in terms of obesity? It means let's make it really easy for people to get healthy exercise. Let's make it hard for them to become a couch potato. Let's make it really easy for them to get healthy foods. Let's make it a little harder for them to get just sugar snacks. And we do just the opposite in the United States. And why are we surprised that we have a big obesity problem? the key elements of the public health approach, and the first one is the most important. It's about prevention. It's about prevention, prevention, prevention. That's what it is. You're trying to prevent things. For any injury, probably at least a dozen things had to happen, or if you had changed any one of a dozen things, the injury wouldn't have happened. And what we learn from looking at various injuries is that typically upstream prevention, not waiting to the last second, not focusing on the individual who got injured or the individual who immediately caused the injury. But if you go upstream, it's typically much more effective to make changes upstream. It's typically much more cost effective, and we'll talk a lot about that. Public health, of course, is not about named individuals. It's about population-based approach, so that, for example, sometimes I give a lecture to psychiatrists, and if I'm talking like to psychiatrists in Boston, I might ask them, why do you think that Massachusetts has such a lower suicide rate than a state like Arizona, which has the same population? And their correct response is, gee, we didn't know that, because they didn't know that, because why should they know that? That's not what they're interested in. They're interested in individuals. And we're interested in populations. And then when I press them, I say, why do you think that is? Why do you think that is? They'll come up with all these different things like, oh, maybe it's the immigrants, maybe it's the sun, maybe I don't have enough psychiatrists. And of course, it's none of those. What is the answer? Why does Arizona have so many more suicides than Massachusetts? And the answer is guns. And that's the answer of, if I ask you any questions, that's going to be the answer in this. Public health is about broadening the approach rather than narrowing the approach. It's trying to get everybody to help everybody to see it seen as part of the solution rather than part of the problem. So it's less blame and more shared responsibility. The problem with blame, sometimes blame is useful but for prevention, but mostly the problem with blame is that it means, oh, it's somebody else's fault, we don't have to do anything about it. And we want everyone to do something about it. The public health approach is a harm reduction approach. It's basically, let's step back and ask first, we have to agree there's a problem, and then let's figure out how all different sectors of society can help solve the problem, seeing everybody as part of the solution. Gun manufacturers, gun owners, the faith community, actuaries, the police, politicians, hairdressers, and so forth. We've worked with a lot of these groups. We work with barbers now, figuring out how ways they can reduce gun violence. One of the great injuries prevention success stories is the motor vehicle success story. This is a story that we in the injury prevention world tell our graduate students over the campfire, and it's passed down now from generation to generation. And the story sort of goes something like this. In the 1950s, we were told over and over that most motor vehicle crashes are due to driver error. There are tired drivers, distracted drivers, you name it. Drivers make mistakes all the time. If drivers never made mistakes, there'd be almost no crashes. And most motor vehicle fatalities are associated with deliberate, unlawful behavior. It's associated with speeding, with drunk driving, with texting while driving. If everyone obeyed the law, it's all they have to do, just obey the law all the time, we could eliminate most of the traffic fatalities, including pedestrians, if they obeyed the law. And so what we were told, of course, if this is the truth, which in some sense it is, what should we do? We should educate drivers, and we should enforce the traffic law. Education and enforcement, that's the message of the gun lobby today. Educate people with the Eddie Eagle program, which has been shown not to have any effect. And then just enforce the laws, throw more people in jail. We have the highest number of people in jail per capita of any country in the world already. But fortunately, in the 1950s, public health physicians asked a different question, not who caused the crash, but what caused the injury. And a lot of people were being speared by steering columns, which went right through their chest. Their faces were lacerated by glass when their head hit the windshield and went right through, and so forth. They would leave the road for 1 second and go off and hit a tree or a lamppost, which had been planted right along the sides of the highways. We public health physicians were saying, well, gee, couldn't we make the roads safer? Couldn't we make the cars safer? Couldn't we make the emergency medical system safer? This is actually basically a picture of my first car, which I drove after a year of driver's education, which has been shown not to have any effect on fatality rates. But it's mandated where I went to school in Illinois, and my car, here it is, it had no seatbelts, it did not have any airbags, it didn't have a collapsible steering column, it didn't have a crash-worthy interior, it didn't have laminated safety glass, it didn't have emergency automatic braking, lane departure warnings, rear-facing cameras, blind spot detection. Finally, we have blind spot detection. It's like for almost all my life, we were told the most dangerous thing is somebody's driving there, and I have to turn around and try to see if they're there or not. And it's like, come on, you guys are, people are engineers. They could do better, and finally they have. Roads are much better. Cars are much safer. The punchline, of course, is that, 75 years later, nobody thinks drivers are better today than they were in the 1950s. Drivers today are better about drunk driving. They're worse about distracted driving, and now in Massachusetts anyway, driving with marijuana in their system. But fatalities per mile driven have fallen over 90%. It doesn't mean you shouldn't try to change drivers. It's hard to do. And it's a lot easier, it's a lot more cost effective often to change the agent of injury or to change the environment. And this was the key insight, I think, to this motor vehicle success story, is that you don't have to change people if it's going to be incredibly expensive and not very effective. Instead, what you want to do is create a system where it's hard to make mistakes, where it's hard to behave inappropriately. And then if some people still make mistakes and some people still behave inappropriately, no one is seriously injured. So what does this mean? It means that you're driving along and you're falling asleep and you go off the road and you go hit a tree, you're dead. That's what happened to a friend of mine in the 1950s. But what you have now is you're driving along, you're going to sleep, and suddenly you either hit, if you're in California, bot dots, which go bum, 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 and wake you up, or now if you have a reasonable car, it goes beep, 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 and it wakes you up. It says, wake up, stupid, and you wake up, you go back in line, and nothing bad happens. And that's the kind of system you want. Another example, the reason I put this in is because I was here when they were building this metro in D.C. They spent a lot of time and energy trying to make it so D.C. Metro would be safe. And they did all these things to it with TV cameras and not keeping it, and having no long winding corridors and not having food in there and so forth. They had gone to all the subway systems around the world and tried to figure out where people were getting mugged and so forth, and they built a better system. And at least in the first decade or so, I don't know, I haven't followed it in D.C., but your murder, rape, robbery, and assault rate was about a fourth of what it was in Chicago or New York or Boston or Tokyo. And it's not because you guys were nicer than we were. It just isn't. It's that you had a better system. So, as it was mentioned, I wrote this book about how to prevent gun violence, and this sort of says, here's the public health approach. Here's all the things we can do. It's only $25 on Amazon. There's so many things that can be done. I'll just mention a few that manufacturers could do to reduce crime. It would be really nice if they made it hard to obliterate serial numbers on guns rather than easy. Right now, a lot of guns can't be traced because the serial number is obliterated. Why is it obliterated? It's so easy to obliterate. They could make it hard to obliterate. Wouldn't that be nice? It certainly would, but they don't do it. It would be nice to know when when a bullet was fired and you got the bullet or you got the casing, that you could trace it exactly to not the make model of the gun, but the exact gun. And that's not that hard to do. Is we call it ballistic fingerprinting. It's it's 2024. We can do all these different things. We can do ballistic fingerprinting and make it a lot easier to catch the bad guys. To reduce accidents, there's a lot of things that could be done. About a couple of decades ago, I was at a conference at the American Public Health Association, and we were in line at a restaurant, and a female delegate dropped something from her purse. A nice local went down to pick it up out of his pocket, dropped a Derringer. It hit the ground, bang, it went off, and the bullet went through two female delegates who were raced to the emergency department. We should not have any guns that can go off when they're dropped. It's just silly. I'll talk about childproof guns and magazine safeties in a minute. There's so many things we should have, but one of the things, we should have better guns. We should have personalized guns in the sense that it should be so that nobody else can use my gun if it gets stolen. Right now, there are I think, 350,000 guns a year which are stolen. It's one of the many ways in which it's really easy for the wrong people to get hold of guns. Your cell phone, if you lose your cell phone, you can make sure other people can't use it. You ought to be able to do the same thing with your gun. There are lots and lots of public health successes. There are lots and lots of injury prevention successes. Why not in firearms? I wrote a book a few years ago, again, only $25 on Amazon.com, called While We Were Sleeping. It's 64 documented successes about how the world's been made safer. Fortunately, very nicely, I was so happy injury in terms of both getting good data and research actually mattered in almost all these prevention stories. And it's also 36 heroes whom you've never heard of who have made the world a better place. Some public health people, but almost all advocates who have made the world safer just in this one area, which is injury and violence prevention. Now, we have particular problems in the gun area, which is why we don't get many successes. One is that I think this is the only industry, there may be one other, that has no federal oversight for safety of guns. It's almost impossible. Over the last 20 years, there's a law passed 20 years ago to make it almost impossible to sue manufacturers like the cigarette companies were sued. We have the ATF, the Alcohol, Tobacco, and Firearms, the Bureau, and it's supposed to oversee what's going on among gun shops and so forth, and its hands are tied in numerous ways. One of the things, for example, it can't even it can't even computerize a lot of its data. It's against the law for it to have computerized data. It's just crazy. There are a lot of data and research questions. Do we have inadequate data? The behavioral risk factor surveillance system used to have gun questions. Now it doesn't. Tracing data, which would be really helpful to researchers, which were available in 1999, have not the individual data, are not available to researchers anymore, and so forth. We could do a lot better in terms of the data which we collect and the data which are available. And not surprisingly, we have too little firearms research because not only do we not have great data, but we haven't had much money for research. I always say that public health is underfunded relative to medicine. That within public health, injury prevention is particularly underfunded, and within injury prevention, firearms research was probably the most underfunded. And I think most of you know the story about the big decrease in the decline in CDC gun research, which never started out much at all, 2.5 million, and then for a long time went to zero, and now it's back up to 2.5 million. Here's the thing I used to show, basically, from NIH, the disparity from 1973 to 2012. In terms of research awards. During that time, there were 3 NIH research awards about firearms, and there were almost 500 about cholera, diphtheria, polio, and rabies, which caused somewhat different amounts of problems in the United States. And things are better, but this just shows you, this is a graph of empirical articles on firearms through the years, which you can find in PubMed. And you can see just very few. In 2007, 2008, there were only about 5 or 6. I thought we must have done most of these. It's crazy. But finally, beginning in 2015, there are more and more and more. There's more and more money. And it's still so underfunded. But things are getting much, much better. More and more people are interested. The reddish line is the number that were funded, and the others are basically had either no funding or no declaration. So whenever there's a big tragedy, I get calls from the media and talk to them, and I mention research, and they always say, well, what do we need more research about? What's the one thing we need to know? And I try to tell them, there's not one thing. It's sort of like answering a cancer researcher. There's been no cancer research for the last 25 years. What one thing you need to know? And the answer, I guess, is how to cure cancer. But I don't think that's the right answer. We know almost nothing about most of these things. I think there's been one article on gun theft, empirical article. I don't think there's been any empirical articles about open carry. It's just incredible how little we know about so many things in the gun area. The first step in the public health approach is to create a good data system. There is a really good data system for motor vehicle deaths. Every time there was a motor vehicle death, there were about 125 pieces of information collected consistently and comparably across states. So we knew a lot about what was going on in motor vehicles, which is one reason there was a big motor vehicle success story. Finally, we have the National Violent Death Reporting System. I think one of the great things that I did in my career is the tiny little role I played in helping create the National Violent Death Reporting System, which is now, after 20-some years, finally in all states. Here's what happened in 1999. We had our pilot. I used to be a shill for this system, saying how important it was to create a data system which was consistent and comparable across all states about all deaths, violent deaths. And I would give a group like you a quiz and say, you'd have this, and you'd say, what proportion. What are the three most common characteristics leading to fatal gun accidents? Where do teen firearm suicide victims obtain their guns, and so forth and so on? And whoever got the most answers right got a prize, typically a shirt that said, support NVDRS. And what was the answers to these? And the answer, you turned the sheet over, and the answer was nobody knows. But if the people told you they knew the answer to this, they were lying because there was no data about any of these things. And that's one of the things the National Violent Data System has done, is provide lots of data. Data are crucial not only to refute misinformation, but I think one of the big things that people don't recognize is how important it is to provide insights about what are the best policies. So an example, I'll talk about unintentional firearm deaths. Then I was going to talk about suicide. There was the darling of the gun lobby, at least the researcher who is John Lott, used to go around saying over and over on Fox News and LA Times editorials, and you can look this up. He said, quote, about 2/3 of accidental gun deaths to children are not shots fired by other little kids, but rather by adult males with criminal backgrounds. And I was trying to say, where did you get this data? And the answer is, I don't know where he got it. I still don't know where he got it, because it turns out to be completely wrong. But if you thought this was true, maybe you should do something about adult males with criminal backgrounds. But it's not true. How do we know this? From the National Violent Death Reporting System. What we know, for example, now is that for children aged 0 to 14, it's not adults killing children unintentionally. It's children killing children. About 1/3 are self-inflicted. About 1/3 are other children as shooters. About 1/6 are slightly older teenagers as shooters. A 15-year-old shoots a 14-year-old, and maybe you're in the same class, but we had to cut off at 14. And then about 1/6 are adults, almost all parents, with no indication that they are criminals. Here's just one little table you could draw from what we looked at. This is sort of unintentional firearm deaths to children by age. And you can see it sort of keeps going up, except 2 to 4-year-olds, a little anomaly. It's higher than the 5 to 10-year-olds. It's almost always all male victims, almost always other inflicted, except for the 2 to 4-year-olds. Almost always at probably your own house, except for the 11 to 14-year-olds, where it's often at a friend's house. And just knowing that sort of helps. What you know is that it's mostly shot, these kids are mostly shot by somebody else. But 2 to 4-year-olds have a relatively high rate of accidental deaths, and they shoot themselves. And basically nobody is shot at a friend's house before the age of 11. So what's the policy? Well, we had a problem, 35 years ago with children finding aspirin bottles and opening them and taking a lot of aspirin pills and dying. And what you could do, you could blame the parents, you could blame the kids. But we decided as a country to solve the problem by having child-proof aspirin bottles. You could have child-proof guns. It's not difficult. Why do we know it's not difficult? Because 130 years ago, more than a century ago, Wesson of Smith & Wesson fame cared about kids and decided to create a child-proof gun. And what he did is he said his guns were going to be so that if you want to fire the gun, not only do you pull the trigger, but you have to put a little pressure on the handle. That's all. Just had to do 2 things. But 3-year-olds can't do that. They can't figure out. And the aspirin bottles how to push down and turn at the same time. And you could save all these kids, but we don't do that. For males over 10 years old, there's the ASK campaign. They're at their friend's house a lot, and a lot of them die there. And you could ask, you say, is there a gun present? If there's a gun present, is it going to be locked up and stored appropriately? Then one of the nice things about NVDRS is that they have narratives. There's a narrative, a summary of the narratives by the police and one by the medical examiner. I've read so many NVDRS narratives. And for the unintentional firearm deaths to children, the most common thing that comes up over and over and over is a boy finds his dad's semi-automatic pistol. He takes out the magazine. Here are the bullets. This must be unloaded. There's nothing that says it's not unloaded. There's nothing that says anything. He pulls the trigger. And 95% of the time, nothing bad happens. And I give talks, and afterwards people come down and tell me, oh, yeah, that happened to me, and I shot against a wall, and my sister helped me cover it up, and whatever. But occasionally, the bullet goes off. It hits somebody, typically a younger brother, a younger sister, a best friend, and somebody dies. And then the question is, what can we do? What can we do? Oh, what we tend to do in the United States. Let's blame the kid. Let's blame the parents. Let's unsuccessfully try to sue somebody because we can't sue the gun manufacturer. Or let's solve the problem. How do we solve the problem? Two ways. One, make it really clear that there's a bullet left in the chamber when you look at the guns. Or even better, take out the magazine, the gun won't fire. In some semi-automatics, you're able to do that. You can just make that mandatory. That's not that tough. You also want safe storage. You want smart guns so that when the kid finds the gun, they can't use it. I want to spend most of the rest of the time talking about suicide prevention. Suicides, many more suicides than homicides, many more gun suicides than gun homicides. And I want to talk about reducing suicides without changing any laws, without changing anyone's mental health. And it's just like magic. Right? Now, one of the things you should know is that almost everybody, when they research suicide, asks why. And that's a very reasonable thing to ask. Why did someone attempt suicide? Why did they die? We asked a different question for the last 30 years, which is how. How did they die? What did they use? And it turns out, if you look historically, that I would argue that most of the success stories, the real success stories, in terms of reducing suicide over the last 100 years, have had nothing to do with changing mental health, have had nothing to do with changing suicide attempts. It had everything to do with changing suicide deaths. In Britain, for example, in 1960s, putting your head in the oven was the most common way. Of over 40% of suicide deaths in Britain at the time were this method. It's how Sylvia Plath died. It's actually a pretty good method in the sense that it's non-painful and it's non-disfiguring, so when somebody finds you, they don't find this horrible mess. In 1970, between 1960 and 1970, the gas was made non-toxic. It was just serendipitous. They found all this great gas in the North Sea and it didn't have carbon monoxide. Suicide rates dropped a third. Third incredible reduction over 10 years. Why? Because people still put their heads in the oven, and they just take them out after a while and sort of go on about their business. Incredible success story. In 1996, Sri Lanka was the country that had the highest suicide rates in the world. Highest suicide rates in the world. How did they die there? Most of them died a horrible way to commit suicide. They drank liquid pesticides. Typically takes 3 or more days to die. It's painful. Medicine can't help you. Then finally, Sri Lanka banned the most toxic of the pesticides, which even the United States had banned. What happened is suicide rates dropped by 50% between 1996 and 2005. There was no change in pesticide attempts of suicide or changes by total suicides by any other method, by other methods. There's no change in total output in terms of the rate of increase in agricultural output. It was just an incredible success story. It was just by changing the method, the available means of suicide. Finally, here's a gun one. The Israeli Defense Force, which are now in the news, unfortunately, all the time, they had a big suicide problem in the early 2000s. One of the big problems was during weekend leave. In Israel, there's lots of guns, but they're mostly military guns. These young Israeli men and women were allowed to bring their guns home during the weekend leave. They're traumatized, and a lot of them committed suicide with the guns. In 2006, IDF did a number of things. The biggest thing they did, though, was it said, the soldiers, you can't bring your guns home with you. And so what happened, incredible, suicides decreased by 40%, due largely to a drop in weekend suicides. Because these people, even if they attempted suicide, typically they didn't die. Now, how could means possibly matter? Well, the gun lobby will tell you over and over, if you want to kill yourself, you will. If you want to kill yourself, you will. And that's either completely wrong or it's a tautology. And you should take your pick. Why does means matter? First, the acute phase of a suicidal crisis is often, not always, but commonly brief. There has been lots of studies asking people who attempted suicide, even people who had attempted, who were called nearly lethal suicides, people who had done things which they thought they would really die, you thought they would die, they should have died. They die 90% of the time, but some people live. They jumped in front of a bus and got hit by the bus. They shot themselves in the head, somehow survived. They jumped off the Golden Gate Bridge and somehow survived. And these people were asked a lot of questions. And it turns out that one question was, how long was it between when you decided you were going to attempt suicide and you actually did? And for about a quarter, they said less than 5 minutes. For over a half, they said less than an hour. Now, there are some people who had planned their suicides, people who are 90 and have terminal cancer and are in pain and whatever. But most of these people who are dying were doing it pretty quickly. Now, the lethality varies greatly by method. The lethality of the method easily at hand during a suicidal crisis plays a role in whether the person lives or dies. Doesn't matter. Intent, of course, matters, but the available means of suicide matters a lot also, and especially for things which are commonly used. This sort of gives two different pictures of suicide. On the right is what, if you're a hospitalist, who you would see. People who come in for suicide, and basically here's all the non-fatal people. It's 83% are people taking pills and so forth. 11% of people cutting themselves. These are suicide attempts. The suicide completions, over half are firearms. Even though a very small percentage of people attempt with a gun, over half of people in the United States who die, now 55% the most recent year, who attempt suicide, who die from suicide, die from firearms. And why is that? Because the suicide rate, the completion rate, if you shoot yourself with a gun, is about 90%. If you take a lot of pills, no matter how many you take, is about 3%. Medicine can save you if you take the pills. They can't save you if you shoot yourself. Now, but is it a life save? Won't these people just go on to commit suicide anyway? There's no question that a history of a suicide attempt is a risk factor for completed suicide. It is a risk factor, right? But it's only a risk factor. What proportion of serious attempters, not people who just a call for help, but people who have done something which most people thought they would die from what they did. They did something terrible to themselves. They jumped off a huge, high building. People have been followed. We've had a good number of studies now. People have been followed about 20 years. What percent of serious attempters eventually die by suicide? And the answer is less than 10. It really is. And most of the large majority of people who attempt suicide and are saved are happy to be alive. It's not like, oh my goodness, now I'll just go commit suicide again. No, they are happy to be alive. Now, there's also a lot of studies, and the studies are overwhelming, that a gun in the home increases the risk of suicide. Not only to the gun owner, but everybody in the home in the United States, the gun owner's spouse, the gun owner's children. There have been, like 18 case control studies looking at all different age groups. There have been lots and lots and lots, a dozen more, maybe a score of ecological studies looking across cities, across states, across regions. And now there have been a couple of longitudinal studies in California, because California is actually the one place which has good data. And they all show that having a gun in the home is really bad for the home in terms of suicide. We've tried to look at maybe it's that people in the home, gun owners and their families have higher mental health problems or something. And the answer is no, no, no. So this just gives you a feeling of an ecological, it's not a study, this just gives you the feeling for the size of the problem. The study looks at all the states and all the years and controls for lots and lots of things. Just give you a feeling for over a decade, 2011 to 2020, for females. I picked females, I don't know, just because I wanted something else besides little kids. And also to find somebody who it's hard to blame the victim. And what this says is that if you look at unintentional firearm deaths, so you look at not all the states here, we're just looking at not the states with lots of problems, but just the states with lots of guns, and then the states with few guns. And it turns out the states with lots of guns also have weak gun laws. The states with few guns have stronger gun laws. The states with lots of guns are typically the southern states and the mountain states. The states with few guns are places like New England and New York, Massachusetts, where I'm from, New Jersey, where the Sopranos are from, and Hawaii. And what this says is that during this period, there were about the same number of female years at risk. We just tried to keep going until we got enough states, and they were about comparable, so we had the same number of total people. There's actually more women in the low-gun states during this period. But there are 18 women in the low-gun states who unintentionally died in a firearm death compared to 196 in the high-gun states. There are 768 women in the low-gun states who committed suicide with a gun compared to 6,610 in the high-gun states. There are 982 women in the low-gun states who are victimized in terms of being shot in a homicide compared to 4,136 in the high-gun states. And this doesn't control for anything, but it gives you sort of just the size of this problem, and it's enormous. It looks like maybe there's a little difference in non-gun suicide across states, but when you look at all 50 states, there's no relationship between gun ownership levels and non-gun suicide or non-gun homicide. And where all the difference is in terms of guns. In New England, where I'm from, there are 6 states. There are 3 states with lots of guns, 3 states with few guns. The 3 states with lots of guns all the states have about the same number of non-firearm suicides, but the 3 states with lots of guns have high rates of firearm suicide. The 3 states with low guns have low rates of firearm suicide. So I live in Massachusetts. We're so much safer than if I lived in Live Free and Die, New Hampshire. So we've been trying to disseminate this message over and over and over. And, it's not like we're the only people, but, or groups of us. And we've been really successful. In the last 10 years, the Army really understands that guns really matter for suicides. The veterans really understand that easy accessibility of guns really matters for suicide. All the state suicide prevention strategies and plans now talk about guns and suicide. It really matters. We've tried to do a lot of lethal means counseling for providers and gatekeepers to try to help physicians and others understand this. And then I'm going to talk a little bit about our work with the gun-owning community. Our online, this is helping providers. About over 15,000 clinicians take this online training, trying to understand a little bit about access to lethal means and suicide. One of the things that we've done is try to find common ground with gunners, and the person in our group that does this is a woman named Kathy Barber. It's good she's a woman, I think, to talk with the gunners in this way. She's worked with gunners all around the world. But one of the nice things she did was in Utah, she got herself invited to this safety, trainers who were doing concealed carry training. Utah is a very red state. It's lots of guns. It's probably the gun training capital of the world. It trains traders in lots of states. And she said to them, you're trying to do a really good job reducing accidental gun death, but do you realize that for every accidental gun death in Utah, there are 85 suicides? And they said, that can't be. How's that possible? And she said, raise your hand if you know someone who unintentionally killed themselves with a gun, and a few hands go up. raise your hand if you know someone who committed suicide with a gun. And every hand goes up because these older white guys, and that's how they die most. And they said, all right, that's really possible? And she said, well, maybe, what if we created a model? Do you guys talk about suicide at all in any of your trainings? They said, no. And she said, it's 85 to 1. What if we worked together and created a module? Would you use it? And she said, maybe, let's see. And they worked together and they created a module. And they love the module. They just think it's the greatest thing. And the module basically it's a message similar to friends don't let friends drive drunk. And basically it says, if your friend is going through a bad patch, it should be your responsibility, and he should know it's your responsibility to, quote, and this is their words, babysit the gun. So your friend is getting a divorce, he's drinking, he's talking crazy. You should take his guns. He should hand you his guns. He should know. You should say, you really shouldn't have your guns for a while. And then he gets a new girlfriend, things get better, he gets the guns back. And they love it. They created, this is their thing, they created the best PSA I've ever seen. It's this gunner. He's at a gun range. He's clearly a gunner. He's at the gun range. He has his nice ears, so he doesn't, it's not too loud. And he's going, bah, 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 bah. And then he turns to the camera and he says, last year things were really going bad in my life. I just didn't know what I was going to do. And my friend babysat my gun for a while, and, I think they saved my life. And then he goes back, bah, 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 bah. And that's the end. And it's a big success story. It's just an incredible success story. And they love it. And not only, they call it the 11th commandment of gun safety, consider temporary off storage if a family member may be suicidal. About the public health approach, it includes not only changing the product, not only changing the environment, but changing social norms and finding allies to change social norms. We're trying to change social norms about guns and suicide. One of the nice things about working with these people in suicide, because, they were approached by Kathy as part of the solution, not part of the problem. And they became really interested in this because this affects them. And they said, well, let's try to do something let's try to find out more about this. And so they said, okay, we'll get the legislature to do a study to get some data and some research. So they got the legislature and got like $250,000, and incredibly they gave us the money at Harvard, they did. And we found out all these things, and one of the things they required is that everybody link data with us. So for the first time ever, we have data linking suicides with medical care. Every suicide and every attempted suicide in youth, we got background checks. Could they have passed the background check at the time of the suicide? Did they have a concealed carry permit? Was this their own gun? Did they somehow, with tracing data? Nobody's ever done this before. Nobody's ever done this since. We can't get Massachusetts to link the data, but they were able to do it there. They also said, this is really important. We think people, the gun trainers should do something about suicide. They should use this module. And they said, how can we do this? We could try to convince all of them, but that's too hard. There's so many gun trainers. We'll just make it mandatory. We know everybody in the legislature. We'll just say this. So now Utah, the red said it's required if you teach a concealed carry class that you have a module about gun suicide. It's one of 3 states. Massachusetts is one because I was on some committee and pushed for it in Massachusetts. So anyway, a decade ago, suicide prevention practitioners weren't really talking about guns. Now they are. A decade ago, firearm experts weren't talking about suicide. Now they're beginning to. Gun shops, gun ranges in 20 states who we've worked with include suicide prevention outreach as part of their mission, which is really nice for gunners. But the big problem, we got a long, long way to go, even in this little area. Only 30% of physicians in the United States understand that a gun in the home increases the risk of suicide. 70% do not understand it or do not believe it, even though the evidence is overwhelming. And unfortunately, 85% of the public, including almost all the gun owners, don't yet believe it, don't understand it. And so they're bringing this incredibly dangerous product into our house that really increased the suicide rate threefold to their children, and they don't understand it. Anyway, again, Amazon. Thank you.
Hi, we do have a couple questions. Those books actually were mentioned in our staff message. So they're great. And just to remind everyone, we do have a reception, and on this snow day, I can say that
There'll be enough food.
the participant to cookie ratio is is very much in your favor. Okay, so anyone's free to use the mics if you have questions. I'll start from the online ones. Let me go from the first one. This came in early. I've read that in Switzerland and perhaps Canada, sorry, it's a missing word. They have as many or more guns per capita. Is this true? And if so, why do they have fewer gun deaths? Does it have something to do with health disparities or mental health?
So let me talk first with Canada. Canada does not have nearly as many guns as the United States. Michael Moore said they did, and he was completely wrong. It's so annoying that he said that. Secondly, their guns are mostly long guns, whereas ours are a lot of handguns. Mostly what guns are bought, not used, are handguns. We have military weapons. They don't have military weapons there. And they have very strong gun laws. So, for example, if you to get a gun there, you have a waiting period. You have a long background check. It's more like an FBI check, and you have to tell your spouse and your ex-spouse that you are getting a gun, and they have to approve it. So it's a very different world. Switzerland. I'm trying to remember Switzerland because people have done these studies about Switzerland. Is God, I can't remember. I get confused with Israel. I tell you, if we had the gun laws in the United States that they had in Switzerland, all the rabid gunners would claim that this is the most unfair system. They have much stronger gun laws. And a lot of their guns, like a lot of the Israeli guns, are military weapons. They're not, you say, yeah, they have guns, but they're owned by the military. They have all these regulations. They have to be stored correctly. And separately from the ammunition, if they find that you have opened the ammunition, you can be, court-martialed. One of the things, too, is that we know that there's a change in Switzerland, so it reduced the number, I think, people who had to go into military service, and that really reduced the suicide rate because it reduced the gun suicide rate among that particular age group.
Let's go in the house. Should be. Keep talking.
Okay, I will. Thank you so much, Dr. Hemingway. This is really interesting.
Frightening.
Yeah, frightening too. So my question is about Utah,
Yes.
and then how to find allies. So it's amazing that woman who went to
Yes.
and really connected to
Yeah.
people. And then I think something like gun violence, it's very hard to just completely forget about your moral state or how you actually feel about, whether you're owning guns or not. And, some people think it's great and other people think it's a horrible thing. So as a researcher, public health researcher, how do you overcome that? Because then I'm saying that if you fake it, smell it, and then you can't find allies. So what's your advice?
Yeah, so the notion is it's not guns or not guns. It's basically people who own guns and people who don't own guns all want people to be safe. It's not like the gun owners think, oh, we want people to be unsafe. They think often that it makes them more safe, even though the evidence shows otherwise. But it's not like the evidence for suicide. It's overwhelming, but for some things, it's not. Yet, it's certainly what the evidence shows is that if you have a gun, it'll increase the chance, of course, for unintentional firearm injury because it's hard to be injured with a gun if no one has a gun around you. And it increases the evidence is very strong, increases the risk that the woman in the house will get killed. But it's not, again, the risk is, it's not like, most people's husbands kill their wives. They don't. Very, very few do, but if the people who are likely to, if they have a gun, they're much more likely that the woman will die. It's finding allies it turns out, not that hard because most people believe in most of the things that I believe in, not only about public health, but also about that 90% of the U.S. population, or it keeps changing from year to year, but it's that ballpark, want universal background checks. The gun owners want it. Everybody wants it, but we just don't get it. If I had a list of 30 kinds of laws that I would like to see, and again, I would like to see lots of things besides the laws, there'd be consensus about well over half of them. Gun owners themselves, not only would the majority of U.S. citizens want them, but gun owners would want them. We just don't get them. We don't have a system that allows us to get all the things that I think would be good for us. So, yeah, it's hard to find allies among the leaders of the NRA, because they have a different agenda. But for the average person, it's really easy to find allies among gun owners and gun people who work at gun ranges and people who own gun shops. It's not hard.
Can I follow up with a related question? It says, I'm preaching to the choir, but why do you think there's so much resistance to these sensible recommendations that you make? I didn't hear you say ban guns. Your message is risk reduction and safety improvements.
Yeah. Well, it's at the individual level, there's not that much resistance at all. I mean, everybody I talk to is a gun owner says, "Oh, that sounds right. I thought you wanted to take away everybody's guns." I said, it's now against the Second Amendment to do that, and that's not this is about harm reduction. But, it's a political issue, and unfortunately, even the people who would like to see most of the things that I talk about, too many of them vote for people who take money from the National Rifle Association and other groups, and they try to convince everybody that you do one good thing and that's going to lead to terrible, terrible things in the future. And it's a political issue. We have one party in the United States who is coalesced. This is unfortunately part of the culture wars. That's all it is. There's all these other things about part of the culture wars too. It's not just the gun issue. We have to figure out how to separate some of the silly things in the culture wars.
So I've always liked the propositions for making safer guns, and you talked about several examples of that in your presentation. And I probably should have started with great talk because I really enjoyed it. But to get to the question, you compared gun safety and car safety.
Right.
And one of the things that's always struck me about that is cars, I think, have a relatively short life on the road. And so, in 5 years' time, people will have kind of usually swapped out cars. There are cars that have been on the road longer, certainly. But, I think the average lifespan of a car is somewhere around 5 years.
No, it's like 15 years.
Is it 15? Okay,
yeah.
Well, either way.
You're just too rich.
I am too rich, it's true. I am giving out money for anybody who wants it. No, but even so, I have a sense that the lifespan of a car is shorter than the lifespan of a gun.
Yes.
And how do you... what is the approach for, if we can get through the bridge, through getting to a point where we make safer guns, how do we swap out those guns so that the safer ones are out there and the less safe ones aren't?
There is an issue that when you're talking about durable goods, this was an issue when in the injury world you tried to make it so that sofas were less flammable. It's like, but sofas last, what they do. And over time passes, which is nice, and the stock changes. Second thing is, there's a lot of old guns out there. People don't use old guns very often, and particularly in crime. If you are someone who's going to commit a crime, you don't want an old gun. The old gun may not work as well, but secondly, there may be problems. How do you get the old gun? You got it maybe illegally. They may have people always talk about there may be a body on it. This gun may have been used to do other things, which now you can be charged with. And so almost always, people are using pretty new guns. And so it's like for, in the cities where there aren't many guns, it's typically, a new generation comes along. How do they get guns? And they're not using their father's guns. They're trying to get the new guns, the hottest guns, whatever. And if you can make it a lot harder for them or make them, it's very helpful. One of the things in both psychology and economics where which I've been trained in, is you want people not to do things as much, just make it harder. Just raise the price. That's what, we've learned about, sugar-sweetened beverages taxes. You just raise the price a little, and it has an effect. And that's what this is just doing, is raising the price, making it harder to get the wrong kinds of things. But yeah, the longer we allow AK-47s out there and more people buy them, the harder it is to get rid of them. I mean, Australia bought back all their assault weapons, and for at least 18 years stopped having mass shootings. And who knows cause and effect, but gee, they had a lot, they had 11 the previous 18 years and 0 in the next 18 years, so it looks good. But yeah, then you have to figure out, do we want to, people say you want to grandfather things or not, or you can buy things back, or you can just let time. Putting in airbags is the same thing. It's like if cars last 15 to 17 years, it'll take a long time. The answer is, I can tell you, at my age, 17 years does not seem that long anymore.
Let me conclude with a comment from this is the NIH Office of Behavioral and Social Sciences Research. So someone writes, thank you for your talk. I would like to make sure that the NIH audience is aware that there has been an active and growing portfolio of NIH-supported research on firearm injury prevention, including suicide prevention, addressing many of the issues discussed today, and much of the work in partnership with communities, gun owners, etc. They give their website. It's OBSSR.
And let me ask you this. What percent of the NIH budget are we talking about? Let me just see. Epsilon, does that sound like the right number?
Higher than 0, so it's
and it's probably the fastest growing from virtually 0.
There you go. Right. Okay, and lastly, the CME code was 50108. Dr. Choi, any?
No, I just want to thank Dr. Emily for coming and brave the cold weather, and for those who are in the audience attending the lecture, and for those who are online, enjoy your hot chocolate, and we're going to go out and eat the cookies. But until then, we'll see you next time. Well, somebody else is going to be moderating. Thank you.